So now we're up to bursitis, and at this point, one of the key things I wanted to make sure that I went back and revised with you all were the dislocation that we looked at yesterday, the posterior dislocation of the shoulder. So we added some extra x-rays here. We discussed the various signs that you can see in an x-ray that you may not have had much practice with, right? So these two, the posterior shoulder dislocation image on the top left and the one on the bottom right, are both showing dislocations where you lose the overlap that you would normally have with the glenoid and the humeral head, right? So here in this little image, you can see this bit of an ellipse that forms here where the overlap is happening, right? The overlap is happening with the big glenoid fossa on the left and the large humeral head on the right. Those two guys are overlapping with each other. Here you can see there's no overlap, right? So you have your glenoid and you have your humeral head. The two are not overlapping because they are not together. This lack of an overlap is something that's going to be a big way for you to know that the person has a posterior shoulder dislocation. This is going to be extremely critical in questions where you don't have much information, right? So the question might not tell you much and just give you an x-ray after introducing you to the patient and expect you to be able to figure that out. The other thing we learned besides this lack of an overlap that lack of an overlap had different names that were created because of it, right? So you had your light bulb sign and the Trow line sign which were forming. So the Trow line were these two different lines you could see, and then the light bulb is the yellow outlining they're showing you. So it's just extra things for you to kind of identify, because the other thing that can happen, there's 3 scenarios you can get with most anatomical questions of this manner. You can get question type 1, which is this question itself. They describe everything verbally. Question type 2 would be one where they just give you the x-ray, don't describe much, and then expect you to figure out the answer. And then question type 3 would be, once again, a verbal one, but it will be one where they verbally describe the light bulb sign and the Trow line sign, rather than describing the physical appearance. In this question, they had the physical appearance of the patient that manifested the answer for you, right? So here, it was the fact that the person was sitting, where they say it, she holds, so this patient was sitting with the right arm adducted and internally rotated with a loss of external rotation. So what we talked about yesterday that was very critical and important to review was the fact that when you have a certain dislocation, you yourself cannot move in that direction, right? So like if you have a posterior shoulder dislocation, then you can't move your shoulder posterior anymore. You can't do that, right? So this is why you're seeing loss of external rotation of the right arm, right? This patient is unable to do that external rotation because the shoulder is externally rotated, so now you lose that ability to, by option, do an external rotation. You don't have that option anymore because you have a traumatic event that is forcing you to stay almost externally rotated all the time. So because this weird action has taken place due to the trauma this patient went through in the seizure that they had, the body naturally tries to fix this by activating all the antagonist muscles that would pull this back into position. And that's why she's sitting with her right arm adducted and internally rotated. It's almost like her left hand is kind of pulling this back in, right? But it's not her left hand, it's her other muscles on the front that are pulling this back in. So this is why the patient is sitting with the right arm adducted and internally rotated, trying to make herself feel better. If she was to stop doing this, or maybe her muscles are all kind of dead and she couldn't do this, that posterior dislocation would only get worse because things would keep getting pulled more into the back, with the back muscles succeeding in pulling that in that direction. So this being said, this question and the things we talked about in terms of x-rays should bring a lot of confidence to you should you ever see a question where you need to pick between a posterior and anterior shoulder dislocation. CK will shy away from some of the more high-yield step 1 questions, right? Like step 1 was all about the sits muscles with the shoulder dislocation and the various muscles that were involved, right? The teres muscle, these supraspinatus, infraspinatus, those guys, they're not that much of a significant thing. Now, of course, they are still significant, and you could still get questions on them, but you should also be pretty adept at them if you finished step 1 already, because by that point you needed to know that really well for step 1. Right now, when you come to CK, you still need to know it, but you need to know some other things a little more importantly, because these are going to be the things that are going to be more CK specific. Other than that, the rest of the things we talked about were just general reading that you can do on your own and master. Just understand one last thing in this question was the fact that they also told you there was no sensory deficit, which really helps, because besides having that cranial nerve mnemonic with my brother says, I forget what it is actually. The whole my brother says big brains matter more, or marry money, whatever that mnemonic was for the cranial nerves, that helps you memorize all the cranial nerves and which ones have even a bit of a sensory innervation, or both innervations, or just muscular innervation, right? On top of that, you just needed to go back and look at, as I said, the step 1 page, the step 1 first aid page, where you look at all the cranial nerves and what they do together, right? So when you look at all of them on the same page over there, you get a good understanding of basically what they all do, right here, right? Upper extremity nerves, what they all do, if they have any sensation they provide anywhere, right? Like musculocutaneous and axillary both have that. And then if any sensation deficits do exist, then depending on where the sensory deficit is, you easily figure out which nerve and which muscle may be involved, right? So that's also going to be very helpful as you get to there. And then you do the same thing for the lower extremity nerves as well. Now when you get to the lower extremity nerves, it becomes let me show you. So when you get to the lower extremity nerves, it becomes a little weird, because these nerves are a little less commonly discussed. You don't talk about it very much. So you can see on the top, I did this thing when I was preparing for my step 1. Actually, I made this when I was making the videos for step 1. I summarized the nerves, right, and what they do. And the green is to tell you where they cause sensation. I added any image that I found regarding any questions that may have popped up where I didn't know that a certain nerve had certain areas of innervation, which you can clearly see here that there's a lot of these weird nerves have branches that go to different places and provide innervation only for sensory stuff, not muscular stuff, right? So very important to understand these guys too, and having a little summary like this really helps rather than looking at the entire page, and you get a good understanding of the names of the key muscles that are involved, because you can see here they didn't really list out the exact muscles that are involved. Here they listed out the area where the muscles are, right? So they just write like medial thigh or whatever, but I actually wrote out the full name of the muscles that are in that area, so that you can actually have a good idea of which muscles you're picking regarding whatever nerve is involved, right? You want to have this down for yourself, because you should be able to point at different parts of your own body and be like, all right, this is the medial rectus, this is whatever, blah blah, and just actually name muscles by pointing at them. That's something that you want to practice, because you're going to get questions where a patient might come in with injuries to their like lateral thigh or something. You want to know what muscles are there in the lateral thigh. What are those muscles called? What are the nerves that supply the muscles in the lateral thigh, the lateral leg compartment, and so on and so on. You want to have a good visual understanding of the way the nerves actually flow throughout the body, right? So there's a lot of anatomy. Teach Me Anatomy, this image right here, Teach Me Anatomy is a really good website that I recommend, made by a common individual, not by like a big time company. And that guy did a really good job with the drawings he has and the explanations he gives, and it's a free website, so it's totally worth utilizing when you're ready to master your anatomy. And then we talked about carpal tunnel syndrome, and now we're up to the topic of bursitis, which I was opening up in the two first aids, so the first aid 2020 and then the brand new first aid 2021. And I found it really funny how all they changed was they took this guy who is seemingly white over here, and the only change they made was to turn him into a black person, apparently. I can't imagine what that was supposed to help with, though, because there was nothing that you couldn't really see. I mean, I get what else they did. They made the bone visible inside to show you the crack, They could have done that on a white person too, but the real problem with this image was the fact that when you look at this leg, as I wrote that here, when you look at this leg, you kind of may not realize that that's actually this person's left leg, a person that's standing looking at you, and this is their left leg being hit with a lateral force. Right, so it's really hard in this image to imagine how the rest of the body must be, because where's his right leg then? You know, I can't imagine how this person is standing. So this image is a little distorted in a weird manner, but just remember, whenever you do ever look at this, that this lateral force was onto the left leg, right? So it is definitely something weird. But bursitis is usually a question that here they don't really talk about it much, so that's when we're going to refer to the first aid, step 1. That involves someone who has a weird thing occurring that doesn't fit any muscular injuries, right? So it doesn't really fit any kind of specific it doesn't fit any specific what do you call it, muscular injury per se. Let me see something real quick. Okay. So going on, here they tell you inflammation of the bursa by repetitive use, trauma, infection, systemic inflammatory disease, various microcrystalline disorders like gout, and then of course the ones that we know from step 1, right? The Baker cyst, the housemaid's knee, and the infrapatellar bursa. So these bursae are little pouches of like this. Right? So little pouches of fluid that are supposed to help the bones sit together pretty well. And you can see the UWorld questions here regarding some of those bursa. So you have your suprapatellar bursa, which is above the patella, subcutaneous prepatellar, which is in front of the patella, and then you have the infrapatellar, which is under the patella. So those 3 are very easy to remember. And then there's just fluid in between the 2 big bones of the legs as well, which of course help you not feel that arthritic pain, right? Now in questions you get your prepatellar bursitis, right? Inflammation of the prepatellar bursa in front of the kneecap can be caused by repeated trauma or pressure from excessive kneeling, also called housemaid's knee. And then you have the Baker cyst, popliteal fluid collection in the gastrocnemius and semimembranosus bursa, commonly communicating with synovial space and related to the chronic joint diseases of osteoarthritis rheumatoid. And then they give you images here showing you that. And so all of them. Now C is the one showing you how the issue is kind of forming this big thing right there, the white one, right? And that's a cyst, right? So it's full of fluid, which is why it's all showing up white in this image. And it's at pretty much the same layer as around here. It's at this level right there somewhere. So how is this usually going to present? Well, these questions kind of did the perfect job for it. I didn't really find any CK questions per se about this. But here we see a 42-year-old, as this question says, 42-year-old man comes to physician for 1 month of worsening right knee pain. He has not had any trauma other than stubbing his toe 3 days ago at the garage where he works as a mechanic. Examination of the right knee shows swelling and erythema with fluctuance over the inferior patella. There is tenderness on palpation of the patella, but no joint line tenderness or warmth. The range of flexion is limited because of the pain. What is the most likely underlying cause of his symptoms? So, already you could tell the fact that there's no trauma, but he has worsening right knee pain. So worsening right knee pain is a unilateral right knee thing, right? It's not happening all over. And then when they examine it, they just see swelling and erythema, nothing much else, but it is under the patella, right? They described it. It's inferior to the patella. There's tenderness on palpation, right? The flexion and stuff is limited because of that tenderness. The only answer that you could possibly pick was because of his occupation, right? That he works at a garage, where oftentimes, what you do end up doing is kind of having to be on your knee and be on the floor to get under the car and stuff like that. So inflammation of the periarticular fluid sac was the correct answer here, and it's the prepatellar bursitis that's kind of occurring for this guy, right? Professions which require frequent kneeling, carpet installers, masons, plumbers, mechanics, these guys are all at risk of developing this, right? Maids also count in this group. Here, I think, let me see. So this one is pre-patellar, right? So this question was also pre-patellar. So let's see what happened here. 46-year-old gardener. So once again, gardening also, when we imagine a man gardening or a woman gardening in the backyard, often involves having to get on your knees and dig in and then put everything in there. Right, so it began abruptly 3 days ago and improved only minimally with acetaminophen. He spends hours on his knees several times a week while working. Exam of lower extremity shows no visible erythema, but there is sharp pain on palpation. Passive range of motion is normal in all joints, but he has severe pain when walking. So in these questions, what you notice, very different from osteoarthritis, rheumatoid arthritis questions, or arthritic questions in general, is that the pain is only going to be in one specific area, and it's rarely ever someone who's so old that it could be actually bone-related pain, right? So it's really never that. They'll tell you, like, one of the things they're not mentioning in this question that you can assume is not a problem is that weight bearing is not a problem, right? They don't have any issue bearing any levels of weight or anything like that on that one knee. Usually if it is a knee injury or if it's knee-related arthritis where you no longer have the fluid in here, right? You don't have the fluid in here, the bones start rubbing on each other and that hurts like crazy, and then of course you can't bear any weight. They'll often also mention the patient is obese or something, or in African American patients who don't work out and are postmenopausal, right? Stuff like that. Those are patients that are a whole different group, and they're not going to be related to bursitis questions. But bursitis questions will do their best to try to confuse you into picking one of these other issues. So you want to be very careful with that, right? So that's all there is to understanding the bursitis aspect. Here they have something called pes anserinus pain syndrome, also called anserine bursitis. This presents with localized pain at the anteromedial tibia at insertion of the pes anserinus that is aggravated by overuse, obesity, knee osteoarthritis, and pressure from the opposite knee while lying on the side. Valgus stress test will not aggravate the pain because it's not related to the ligaments, and x-rays will also be normal. So this is a very specific case scenario, as you can see, the way they described it, right? This is very, very specific. On the right, they've written median nerve injury leads to benediction sign caused by an inability to close the first through third digits. Ulnar nerve injury leads to claw hand. Why is this over here? Alright, well, just another key fact. I mean, this will actually go back and revise too, because I got really good at this with something I kind of utilized when I was studying. But yeah, pes anserinus pain syndrome. This is just a pain syndrome that is not due to a ligament injury, and is also not due to any kind of bone injury, right? But the patient could have osteoarthritis, right? So you can see how this question is going to be very confusing in the sense that just now I just said that the question would not have obesity, being African American, arthritis, stuff like that, right? That's your typical bursitis question. This bursitis question, though, with the anserine bursitis, will have all of that, right? Overuse of anything can lead to osteoarthritis. That's exactly what osteoarthritis is. It's arthritis that you develop from using whatever bone too much, whereas rheumatoid arthritis develops just because it can develop. So this is something you want to be very careful about. I think the only way you really will get this correct is because you'll see x-rays are normal and that any test they're performing is coming back pretty normal, right? But they have a pain syndrome, and that's what happens with pain syndromes, right? Just like with opioid withdrawals as well. That's another type of a psychological pain syndrome where there really isn't any cause for pain, but there's pain. So it's just a pain syndrome. That leads to the next topic of more pain syndrome related stuff. So here we see patellofemoral pain syndrome. Another little quick topic right here, right? So this is anterior knee pain caused by overuse, which again, overuse almost always indicates osteoarthritis, right? So you want to be very careful not to fall for that, not to fall for that. This overuse topic of anterior knee pain from overuse, it's not always osteoarthritis. You really have to look for other things for it to be osteoarthritis too. When we get to the topic of comparing osteoarthritis with rheumatoid arthritis, you're going to see some of the other things you want to see in the patient to really pick osteoarthritis as an answer choice. right? Just overuse isn't enough. This thing is common in women, obese, and diabetics. Pain can be reproduced with knee extension, treatment with activity modification, and NSAIDs. Presents with localized tenderness, decreased range of motion, edema, and erythema. Patients may even have a history of trauma or inflammatory diseases. Mainly a clinical diagnosis based on symptoms and physical exam findings. Needle aspiration is indicated if it's a septic bursitis, which in that case the patient would have fever, some cause for having infection, but no labs or imaging are necessary. Best initial test is just to rest, hedonize, elevate, and give NSAIDs. So what happens on CK often is that you're going to have to pick the answer of heating and icing it, rather than, the obvious answer of giving NSAIDs. That won't be an answer choice. So then it's often a piss off in that respect, because you get your patient, you figured out that they have patellofemoral pain syndrome specifically because you can see where the pain is occurring and it's pain. And then maybe they fit the dynamics of, common in women, obese, and diabetics. So it might actually be an obese diabetic woman. So everything fits. You figure it out as patellofemoral pain syndrome. You immediately thought in your head, we need to give this person NSAIDs. They ask you the question, what's the next best step? And then your only answer choices that you have don't include NSAIDs. So then the only answer choice that might actually be included would be this one, and you would have to pick it. But oftentimes what happens with such an answer choice, heat and ice, is that we as medical students will think it doesn't feel very medical of an answer choice, and we don't want to pick it. So you got to be careful with that. It's actually the correct answer, and you need to go with that. Don't get caught back by it. We don't always have to pick an answer choice that involves medication, but you do have to pick medication if it was septic. If there's antibiotic necessary, then you have to give them the antibiotics. Right? So that's all this little topic is really about. So patellofemoral pain syndrome. So that's again going to be in this region as well, the patella and the femur. Right? Very rare type of a question, but the reason you need to know it is because once they teach it to you, they can test you on it, and the differentials are pretty much everything else that can occur in that same area. Right? So it's very hard to be able to differentiate things that are very similar if you don't know the one specific thing that makes it whatever it is. The other thing that makes such tests hard is the fact that they're going to ask you what is most likely the problem with the patient. And at that point, multiple things could be a problem with the patient, but you have to pick the one that's most likely. That always sucks, right? So it's very well possible that a question might occur with everything that's being said over here, but it's actually osteoarthritis, not patellofemoral pain syndrome. And if both answer choices are there, it's going to be very hard to pick one over the other, right? So you're going to have to look for more things and stuff like that. Thankfully, both can benefit from NSAIDs, so that's okay too. But just be very, very tentative on what you're picking as an answer choice. Let me see. Oh, and this is a good bubble right here. So, infection of the superficial bursae occurs after trauma to the skin. Infection of the deep bursae is often iatrogenic, following injections or aspirations. So what often shows up in questions is like you might have a patient who is maybe running or walking or going up a ladder or something like that, where they're using their body to do some kind of task, and you might have had someone who like really badly hit their knee against a table or something, right? We don't normally do that very often, so we don't know, but this kind of injury where you hit your knee on a table really badly, possibly even blood, is what actually leads to infection of those bursae. Right, so you have to think of that as soon as you see that in the question. You have to start having suspicion for the infection of a superficial bursa. Whereas people who are getting injections in the knee and stuff, of course you introduced something that went deep inside, so that could be a reason to get a deep bursa infection, but that's pretty rare because we use sterilized things for the most part, right? So that's really not the most common thing, but this gets tested pretty often with people hurting themselves. Over here they talk about a Volkmann contracture. So a Volkmann contracture of the wrist and fingers is actually something that's caused by compartment syndrome, which was one of the things we talked about right here, right? The compartment syndrome stuff, where you could actually have a certain part of your body, any compartment of your body, compressed a little too hard, thereby seizing blood supply or nerve supply. So a vulcan contracture of the wrist and fingers is caused by compartment syndrome, which is associated with supracondylar humerus fractures. These fractures may affect the brachial artery and radial nerve. Ischemia results in fibrosis of dead muscles. So this specific topic that they just mentioned there, let me see, I think I have an image of that here somewhere. Supracondylar fractures. Okay, yeah. So right here, in this page in the step 1 first aid, right, I've put in the UWorld images where they're nicely showing you how the nerves go, right, where they go, what muscle they penetrate. That penetration aspect is a whole different list of topics where you can get questions about anesthetizing anesthetizing a certain nerve, and they'll be like, where would you inject the person? So you got to know where the nerve is before you can pick the answer of anesthetizing it. But here you get to see where the nerves are to get a really good understanding of what's happening, right? Because what kind of fracture can injure certain things. So right now what we're talking about is regarding this, right? Supracondylar fractures can actually injure anywhere, right? And this one right here is in the middle of the arm, where your radial nerve and the deep brachial artery are going behind it and coming down, right? And then they come down and they go like this into the front, right? You have your anterolateral and intermedial humeral fractures, and this is a supracondylar humeral fracture that can be something that could be a pediatric question or an adult question. And this becomes a really weird topic because both cause different injuries depending on what nerve is around. Not the hardest thing to remember though, because ulnar nerve isn't involved. So the ulnar nerve really only gets involved with the hands and more so with the pinky side of the hand, right? But up here, as you can see, there's only two. There's either the radial nerve or the median nerve, depending on what side you're looking at. So the median nerve is more on the medial side. The radial nerve is on the thumb side, more lateral, right? So if you have an anterolateral humeral fracture where the supracondyle, so these are your condyles, right? Lateral and medial epicondyles. The supracondylar fracture kind of moved anterolaterally, then it's going to injure the radial nerve, right? You can see that right there. This is going to then, of course, cause issues with radial nerve innervation below this area. But up here, above, everything's going to be fine. Very important thing to keep in mind, right? Because radial nerve has innervations in multiple places, but the only issue in this specific individual is going to be that they're going to lose radial nerve function below the area of the injury, right? Same thing on the other case scenario too. If you have anteromedial humeral fracture, then the humerus is moved more medially and it compresses the median nerve, right? It can at this point also injure the brachial artery, right, where you could end up bleeding a lot internally. So that's pretty problematic. And again, with the median nerve, the losses are going to be below the site of the injury. Everything above, though, was more proximally. Everything above is going to be just fine, right? So that's generally all this is about. Very specific type of a topic, but, you know, again, like, it shows up. These are the things you have to know. There's a lot of things in anatomy to know, and that's what kind of makes this such a annoying and difficult topic. In this area, as you can see, the ulnar nerve, you see this ulnar nerve coming down over here. It's not really involved. The way it's coming down is not involved with the humeral fractures. Right, so once it comes down into the hand, it's on the upper side. It's going down. It goes into the pinkies, and that's it. Right, so you get your fifth finger and half of your fourth finger being supplied, and it goes through the Guillain Canal, which we saw is a differential for carpal tunnel syndrome. You're going to get Guillain Canal syndrome in patients who are cyclists, and the way you hold a bike, it can cause compression within the Guillain Canal of the ulnar nerve, right? So that's generally all there is for these guys. There's a lot that can happen with these, though. There's a lot that can happen with these, with impingement and injury and loss of muscle, loss of sensation. So all of that, you know, these pictures do a good job helping understand it. This topic here with the benediction sign and the claw hand, another thing that you want to make sure you confidently understand. There's nothing confusing about them, but they're definitely worth, well, it's wrong to say there's nothing confusing about them. There is, they are confusing, more so because Notice how these two pictures are the same picture. These two pictures are also the same picture. The coloring is different. But you want to make them not be confusing, right? You want to learn them. So if we actually break into it, first things first, the coloring is showing you where the problem is, right? So every time the coloring is in the ulnar area, that should be pretty obvious that the issue is with the ulnar nerve, right? The pinky is being highlighted in both the first picture and the last picture. So what is the difference between these two in terms of ulnar? Well, the difference is whether or not you can actually flex that finger, right? So both of them have ulnar injury, but look at the difference. Here you have distal ulnar nerve injury, where somewhere past your condyles, the ulnar nerve has been injured, and then here you have proximal ulnar nerve injury. So what's the problem? Well, if you have a distal ulnar nerve injury, when you try to extend, when you try to open up all your fingers, you're unable to open the pinky. When you have a proximal ulnar nerve injury and you try to make a fist, you're unable to close your pinky. This was really hard to memorize at first until I made up something that I wrote over here. Median nerve affects first three fingers, the thumb, pointing, and middle finger, while the ulnar nerve affects the last two fingers, the wedding ring finger and the pinky. Extension, the act of extending, takes fingers away from the palm, right? You open up your fingers, it goes away from the palm. So the extension issues are always distal, right? Extending fingers not working, distal ulnar nerve injury. Extending these fingers not working, distal median nerve injury. Right? So you can see how now that every time the problem is with not being able to extend a certain set of fingers, then the extension is a distal injury, and which fingers are involved tells you which nerve is involved. Now this becomes extremely easy. Right? Flexion of fingers brings the fingers closer to the palm, so the fist issues are always proximal because you're bringing them closer. Now, of course, proximal means proximal being closer to the shoulder. If the injury is closer to the shoulder, then you're going to have proximal injuries. If the injury is much further away from the shoulder, possibly at the elbow or after the elbow, those are considered distal injuries. That's what the proximal and distal really is about. But as far as memorizing and understanding the questions, you can see now, right? So if the problem is distal, your issue is going to be with extending, and then if the problem involves the pinky, the issue is with the ulnar nerve, so distal ulnar nerve. That's it. Same thing here. If the problem is with extending, then the issue is going to be distal, and if the problem involves the thumb and these fingers, the problem is going to be with the median nerve, so distal median nerve injury, and then you just pick that answer choice and you're done. You don't need to know these names, ulnar claw, median claw, or whatever, but these names are not that far-fetched. They are exactly what you would basically call them, right? This is an ulnar claw because the clawing that's occurring is with the ulnar nerve, right? Making a claw is actually kind of clenching your fist, so they are the ones that are making the claw. The other three fingers are not making a claw, right? Same thing here with the median claw. The clawing is occurring in the median distribution. The pinky is not making a claw. This is an OK gesture. You got the OK right there. And then Pope's blessing is looking like this, right? So if you ever get a question where these are the answer choices, then this is a really dumb question, but it shouldn't be too hard to pick them. And understanding the name of the injury and what the injury is supposed to do, how you're supposed to see the injury, should be pretty commonsensical now after you reading this concept of being away and being closer to the palm, right? So that's really good. Other than that, you can see atrophy of the thenar eminence can be seen in median nerve lesions, while atrophy of the hypothenar eminence can be seen in ulnar nerve lesions. So the thenar and hypothenar muscles are in the palm, right? In the palm. Thenar is with thumb. So the thenar eminence is on this side. Everything by the thumb. Those are your thenar muscles. And they can actually get atrophied really badly when the median nerve isn't working. Whereas your hypothenar are by the pinky. So those muscles in the palm right there, those are going to be your hypothenar muscles that are not going to be working too well, and they're going to lose innervation, so they become very atrophied in patients with ulnar nerve lesions. And so more things you would see in these same individuals. and that's it. So that's a whole topic of its own, where of course you can get one specific question of someone popping up with one of those issues. Don't get confused, don't get lost, and don't mess it up, right? Last thing here on this page was tendinitis. So tendinitis, as we saw in step 1, was the tennis elbow or the golfer's elbow, based off of whether your motion is front hand or backhand, depending on what you're doing. Right? When we play tennis, we do a lot of backhand, a lot of wrist involvement. So if you've never played tennis, one of the key things with playing tennis is that when you hold your racket, you never really bend your wrist. Right? The wrist has to stay straight. The racket is an extension of your hand, so if your wrist kind of bends, the racket bends too, and it's going to fail in hitting the ball in the direction you want it to send. So you have to hold your wrist with the racket in a straight line, right? So since you need to hold your wrist so hard and straight with all that pressure that you're going to create when the racket actually hits the ball, that entire pressure gets mitigated all the way to your elbow, right? So with lateral epicondylitis or tennis elbow, there's going to be worsening with resisted extension of the wrist. Right? If you tell them to extend their wrist, but you tell them to do this, you tell them to extend their wrist, but you stop them from being able to do it, it's going to hurt a lot. It's going to hurt a lot. They can't do it because of the pain and inflammation they have there. Medial epicondylitis is a golfer's elbow, so of course you never golf backhand, right? Golfing is always a front hand swing. So in these people, there's going to be issue when they are trying to flex their wrist and you stop them from flexing it, right? So those are the two tests they're kind of showing you here, right? Resisted flexion versus resisted extension. In tennis, it's a very common thing to swing backwards, right? So that's kind of all you're going to get in the question. Inflammatory condition characterized by pain at the tendinous insertion into bone associated with swelling or impaired function. It commonly occurs in the supraspinatus, biceps, wrist extensor, patellar, iliotibial band, and as a choice you might have to pick, posterior tibial, and Achilles tendons. Overuse is the most common cause. The iliotibial band would be an answer choice you would have to pick simply because they're not going to put one of these other answer choices. And iliotibial band, how often have you ever found yourself discussing it? Probably never. That's why when they have this as an answer choice, you'll not really be inclined on picking it, right? But it is related to the tendinitis that we need to be aware of. That is shown, let me see where they talk about that. Let's look for tennis. Right here, okay. So you have your medial epicondylitis, which is the golfer's elbow, and lateral epicondylitis, which is tennis elbow. These are the specific of the two, and these images here are showing you, right? So your lateral epicondylitis, you have your lateral epicondyle right here with the olecranon. This is going to be someone who's holding their hand exactly in this manner to hold a tennis racket, right? And when they're holding the tennis racket and they keep swinging backhand, this pressure, so the pressure of swinging backhand involves this insertion point right here. That place gets really, really inflamed and overused, right? Professional tennis players get a lot of massage therapy, So repetitive extension leads to pain near lateral epicondyle. This serves as the primary attachment site of the extensor carpi radialis brevis, ECRB muscle, as well as the extensor digitorum, which is for the fingers. Overuse of the ECRB can lead to angiofibroblastic tendinosis, which again is another thing that can be an answer choice, right? Because you do unfortunately have to know how to describe things in the way that it occurs, I suppose. And you can see how that's not a phrase here. It's not even a phrase here. I wrote that there from UWorld. So angiofibroblastic tendinosis. Fibrosis is obviously what's going to occur with chronic inflammation. So that's why this is what you want to keep in mind as a general pathology understanding. But little to no true inflammatory infiltrate. They don't have a cause for inflammation naturally. The inflammation is occurring because of the activity they're doing, right? And then with the medial epicondylitis, this is the other case scenario here where you can see you have repetitive forehand shots, which is what you do when you play golf. You never backhand golf. And that leads to pain near the medial epicondyle, right? So that's involving a different set of muscles, the flexor muscles, flexor carpi radialis, flexor carpi ulnaris. Those guys are not going to work too well. And see here they didn't explain how you would diagnose it, But in CK, that's what you need to know, right? So with a tennis elbow, if you caused the problem by doing something, now you can't do it, right? So the problem occurred by repetitive extension. Now you come into the clinic, I tell you to extend your wrist, you won't be able to do it, especially when I stop you from extending your wrist. And the same is true for the golfer thing. Flexion is not going to work, right? What's the next best step? Not much. You don't really need to do anything. You'll see it clinically. If it's not very clear, then you would do the ultrasound or MRI to detect tendon tears. But generally speaking, the clinical diagnosis is enough, right? Depending on whether or not you need to see the tear is the only time you would order any imaging. And treatment is pretty straightforward, NSAIDs. But in your question, NSAIDs might not be an answer choice to pick, so you would go with the splinting, bracing, or just pure immobilization until, immobilization and rest go together in a sense until recovery. Right? Begin strengthening exercises once the pain has subsided, and then slowly ease back into the sport. Don't just jump right back into playing the sport nonstop. Right? Next best treatment is consider corticosteroid injections. This is pretty much true for almost any MSK topic where you have inflammation. Corticosteroid injections will cool that area up and stop the inflammation, but never inject the Achilles tendon in view of the increased risk for rupture. Avoid repetitive injection, right? So that's not the answer you will ever pick for the Achilles tendon. And just the thought of getting an injection in your Achilles tendon area should pretty much creep you out and scare you, so don't pick that as an answer choice. You can actually rupture the tendon more by giving an injection there. It's not meant to be cut or ruptured in any way whatsoever. Then they move on now, as we can see, from upper to lower. So that we have low back pain, which is one extremely common thing on step 1 and step 2, right? Low back pain is the second leading symptom-related cause for office visits in the United States, right? Symptom-related cause. Patient has pain, so they come in. Though often self-limited, it can also be a sign of more severe disease, including infection, like osteomyelitis, malignancy, or AAA. So the infection thing we saw a little bit earlier, where a person had a UTI, it got really complicated, and then it must have ascended into their spinal bones, and they had osteomyelitis of the spinal column. So that's something that you see in questions that you may not catch because it's very rare to make that connection. Malignancy is obvious. One that we know of that is associated with back pain is the prostate cancer, right? Prostate cancer metastasizes freely using that prostatic plexus up the spinal column all the way to the brain. So that malignancy can also cause low back pain. And then, of course, your abdominal aortic aneurysm presents with low back pain. Other things are herniated discs, very common thing. Causes include degenerative changes, trauma or neck back strain, or sprain. Most common in the lumbar region, especially L5 to S1. Presents with sudden onset of severe electricity-like lower back pain, which is what we think of with, what's that disease called? Sciatica, right? Sciatica. That's the sciatica thing right there. So when they say electricity-like, in a question they won't describe it as electricity-like. In questions they describe it as shooting pain, right? So that's your electricity-like lower back pain. The shooting pain often goes down all the way to the leg, then is sciatica, usually preceded by several months of aching, discogenic pain. Common among middle-aged and older men, exacerbated by Valsalva coughing, associated with sciatica, paresthesias, muscle weakness, atrophy, even contractions or spasms. A passive straight leg raise increases pain, which is highly sensitive but not specific. So this is often going to be in questions. They're going to do this in the question, the straight leg raise. When you do the straight leg raise, when you lay down on the floor flat, maybe because you're trying to do ab workouts, and you do a straight leg raise, that leg raise really requires your back to be good, right? If it's not, it's going to cause a lot of pain. So here they tell you that the straight leg raise test is sensitive. That means that you could use that to rule out a herniated disc. So if there's no pain, then there's no herniated disc. That's kind of what that means, right? The other thing is your contralateral. This is another thing that will happen in questions. Your crossed straight leg raise increases pain. This one is highly specific, which means you could use it to rule things in. So when you cross the leg and you try to do the raise, that will cause a lot of pain. That's actually very hard for even a normal individual, and that would tell you it is a herniated disc. Large midline herniations can cause Cauda equina syndrome, which is a huge topic in neurology step 1. It's also going to be in neurology CK, and that in itself is really just related to midline herniations, but it's one of the lesser common things. The more common thing is just the L5S1 thing, which of course involves the sciatica. Right? Now, what do you do for these people? So you do diagnose it with the straight leg raise test, or the other one. You could do either one. If you do the leg raise test, you'll see it in the question. I think I have a question somewhere eventually as well where that does occur. When you do the leg raise test and they have the pain, it already tells you a lot's happening. Then you can go ahead with imaging or other tests. Imaging is an MRI. One of the special things of doing an MRI is not only that you get to see what's happening, you can see the herniation like in this image right here, but MRIs will also expose if there's osteomyelitis. So that's also pretty good. Right, this is a sagittal T2 weighted MRI of the lumbar spine showing you a posterior herniation in the L5S1 area. So you see how it's kind of squeezed out, and now it's squeezing on the nerves coming down over here. Right, and that's going to cause a lot of symptoms. We're going to go look at that right away. MRI, necessary for Cauda equina syndrome for sure. Rapidly progressing neurologic deficit. Other tests you could get are ESR, plain X-ray if other causes are suspected. So plain X-ray is really the mainstay of things for looking at osteomyelitis, trauma, or any other kind of fracture. Compression fractures are a thing for patients with osteoporosis, right? So plain X-ray is almost always the easiest thing to do and the easiest thing to pick as an answer choice, and you just do it. MRI you would pick if you know that that you did the passive straight leg test and there was pain. Then you need to go ahead and do the MRI, the preferred test. So now one of the things we need to go back and revise is what happens when you actually compress the nerve at these points. Right, that was a step 1 topic. Let me see where they talk about that. No, not that. Right here. Alright, so signs of lumbosacral radiculopathy. Now, memorizing this is another thing that you spend a day to do it, you get it down, and you should never really need to come back and look at it again. And to be able to memorize it to that way, I came up with a couple things here. So you can see the notes I put here are the extra things that were not in the book at first. And they're going to help you get this down pretty well. So let's say your patient has a disc herniation at one of these 3 areas. The most common is this last one, L5 to S1, which causes you to have a shooting pain down the side of the leg. Right? So this is a person who you're looking at from the back, and this is their lateral side, and it goes all the way down. Weakness of plantar flexion will occur, difficulty in toe walking, and Achilles reflex will be gone. Right? So tibial nerve is involved. Remember with tibial nerve, with the mnemonics we looked at yesterday, PED tip. Let's go back and look at it one more time. The more times we look at it, the better. So the PED tip, right? When the tibial nerve is involved, tibial nerve actually inverts and plantar flexes. That's what it does. It inverts, so medially moves your toe medially, and it plantar flexes. Plantar flexion is like this, so you can walk tiptoe. If you can't walk tiptoe, then you probably have a tibial nerve injury. That's a very easy one to memorize. PED is the other thing, right? So peroneal nerve everts and dorsiflexes like that. So when you dorsiflex, you'll be walking on your heel. You won't be able to walk on your heel anymore. If it's injured, you'll actually have foot dropped, right? So the foot is going to drop, so you won't be able to walk on your heel anymore. In fact, the person who has peroneal nerve injury, their foot is always going to look like this, right? But not because they wanted to, right? With the tibial nerve, you can actually choose to be like this, but with peroneal nerve injury, you will be like this all the time. So now coming back to here, if we're saying that this person cannot walk tiptoeing, they cannot do plantar flexion, those are tibial nerve injuries. So that's what happens here. Right? With the L5 to S1 compression, you actually end up losing your tibial nerve activity down here, and this is the area of shooting like electrical nerve pain you'll get in these people once in a while. Then comes the other two. The second most common was L4, L5. Right, they said the second most common L4, L5. Okay, so that's also testable. L4, L5. Now we're looking at the person in the front in both of these images. The right leg from the front side. So in L4 to L5 injury, you get weakness of dorsiflexion, difficulty in heel walking. So if you can't heel walk, that's because you have foot drop, and foot drop is peroneal nerve, right? So common peroneal nerve is not going to work too well. You know your common peroneal nerve also was kind of going in that area right there where we read about compartment syndrome, that if you have a cast on, it can compress that nerve as it comes down. Right, so that's something we saw just now as well. This, right here, see the common peroneal nerve comes down in that area right there. Right, so it's very fitting, the image that they've given here, that this is exactly how your peroneal nerve was going. Right. So with the common peroneal nerve, you lose these last few fingers on the front. They won't work too well either in terms of sensation. Last thing here is if you have a disc herniation at the L3, L4 level. So you can see how this kind of goes over the patella. Right? So you lose your patellar reflex. Weakness of knee extension. Knee extension is literally when you straighten your leg. Right? You can't straighten your leg. You can't move your leg to be just the way this person is standing, because you need your knee to do that. You need your patella and the muscles attached to the patella to pull the muscle straight up. So that being said, right, how do you memorize this? So I wrote here, L4 affects the first toe. Right, L4 affects the first big toe. L5 affects the fifth toe, all the way over there. So this kind of helps you understand that the wrapping of this color coding we're seeing must go in this way. Right, this wrapping around the leg that we're seeing kind of reminds me of the colorful lighting thing that most barbershops have outside of their door. Right, that's kind of what you're seeing here, right? The wrapping around. So to get a good understanding of how the wrapping around must be going, it helps to remember where the wrapping around is going to end. If it needs to end all the way at the first toe, it has to go over the patella and come in this manner, right? If it needs to end at the last toe, then it's going to come a lot later in this manner. And then right away you could remember right here you have your peroneal nerve, so the problem is going to be foot dropped. In these people, the nerve that's really possibly involved in the area that's highlighted is only the femoral, because peroneal and tibial take care of everything down here. Right, so there's just femoral here. Other things that are up here are your sciatic nerve and your obturator nerve and stuff like that, but the obturator and all of that are more medial stuff, not lateral, right? So they don't count. So knowing the nerve was critical, actually. I'm sad that they never actually had the nerve written there, so that's pretty important, and I wrote it in. Sciatic is the easiest one. Everyone knows about sciatica, and that's just on the back, shooting pain. So very important to understand that. Now, how does the nerve damage actually look? So it's shown in this image here, right? So what you're seeing here is in between L4 and L5, you have this disc, and it's herniated, right? When it herniated, look at the nerve it's compressing. It's compressing the nerve coming from L5. Right? That's how the herniation works. It affects the nerve below the level of the herniation. Very important to know that. So when you pick the numbers, if you look at it, it's always the second number. Right? So if you know that in your question the person is showing up with L5 issues, which of course involves the fifth finger and goes in this distal way, and right here it compresses on the peroneal nerve, then you know that the herniation must have been L4, L5, not L5, S1. Right? It's always the second number that gets affected. The nerve coming from below the area of herniation is the one that gets affected. Right, very important to see that too, so that's why I put this picture here. All of this is like, this itself, this entire thing we just talked about is a topic of its own that you need to be confidently able to discuss. The other topic of its own that we just talked about were the claw hand and the Pope's blessing thing. Another thing you need to confidently be able to reproduce. Like, you should be able to sit down and just draw yourself, 3 pillars, like these legs, right? 3 pillars, and then be able to put the knee there and highlight where the lacking of things is going to be based off of which nerve and which herniation is involved. Like, you should really be able to reproduce this entire table by yourself without the book in front of you. That's when you know you've memorized it perfectly and you can move on to the next topic now, right? So, and that is exactly what I did when I was studying. It's like most people end up either feeling lazy about doing that or feel like it won't be that effective. But I mean, there's only so much you can do, right? It's either you do it or you could just sit and read and do more practice questions, which everyone else is doing. But doing this with extra thing that I'm mentioning right now really helps, really, really helps. You draw your 3 pillars, right? Put a knee on each one of them. And then with your pen, try to draw out the range of where the detriment is going to be, right? That will help you visualize this permanently in your head, right? And you should know with the L3, L4, it needs to affect the first toe, right? The F for first. So it came all the way to the first toe. You write L4 here, and you know that the patella is involved because of the way you drew your line. It went over the circle. And you have to remember that it must be femoral nerve. All of it is F. Right? With the L4, L5, it has to go to the 5th toe. So you draw it a little more laterally, not going over the patella at all. Right? Patella is not involved. You write L5 and you move on. Right? And then the same thing with here. And of course, for each of them, tell this to yourself again without the book in front of you. This is the entire thing that I'm practically always preaching about: studying without the book in front of you, being able to reproduce things without the book in front of you. When you're able to do that, you could talk about it with students and anyone else, any of your colleagues, and of course, do the test without really needing the book. Right? That's the goal. Do the same thing for the hand thing as well. Right? Do the same thing for the hand thing as well, where you can just draw the circle for the palm, and then draw the fingers that are involved, right? Tell yourself you're only going to draw the right hand for each question. So the right hand, if you have someone who has an ulnar claw, then that means that the ulnar fingers, the pinky fingers, must be twisted like that. But the others are just fine. Right, so the thumb and the pointing finger and the middle finger are standing straight, but the ulnar side fingers are clawing in. That's your ulnar claw. What does it mean when you have an ulnar claw? Right, so ulnar claw means that when you were trying to open up your fingers, because clearly the correct fingers have all opened up, right? So when you try to open up your fingers, these guys didn't open up. What did it mean to open up? Opening was a distal injury. So distal ulnar nerve injury. That's it. Right, proximal things were only problems when you were trying to close your fingers. So again, the normal fingers will do what you needed to do. It's the bad fingers that weren't doing what the others are doing. So that's how you figure out what the problem is. And distal versus proximal depends on what is the activity you're trying to do, open or close. Right? So very easy things to reproduce for yourself. You just want to make sure you go ahead and do it. When you do the reproducing of these things for yourself, you get it down really well, and it really makes you feel more confident when you finally see questions of those topics. All right. Last thing here is the spinal stenosis for lower back pain. So in this segment, they're talking about lower back pain caused by things outside of these, not these. Because these things, when you read about them, you'll see the lower back pain. Right now, we're only talking about lower back pain actually caused by musculoskeletal issues. So spinal stenosis is exactly what it sounds like. It's a narrowing of the lumbar or cervical spinal canal, leading to compression of the nerve roots and spinal cord. Most commonly caused by degenerative joint disease, typically occurs in middle-aged or elderly patients. So what you're going to see for the most part, though, is that the herniated disc thing is going to be a male patient, someone who's lifting heavy things or does a lot of weightlifting. Actually, this is almost never a question about a person who's a weightlifter. It's going to be someone who's lifting weights, but not as a professional thing. Maybe because they have to move heavy boxes for a new job or something like that. Weightlifters know that a herniated disc is going to end their career, so they're trained and they have the equipment and they wear the tight belts and stuff to make sure they'll be okay. But when you start a new job where you have to move heavy boxes, you didn't know, and then you mess up, right? So that's going to be male patients. Spinal stenosis questions will usually be female patients. Most commonly caused by degenerative disease, as we saw already. So here they're revising the things we just talked about, right? But you can see how this is also missing a lot of things, so you need both together. Coming back to the stenosis, presents with neck pain, back pain that radiates to the arms or the buttocks and legs bilaterally, and leg numbness, weakness. So the bilateral part is a big deal. Also notice that you're going all the way from the neck to the legs. Neck to the legs. Because spinal stenosis really depends on where the stenosis is. Which nerve did you impact? You may not have involvement of everything, but usually the stenosis is in such an area that multiple nerves get affected, right? You get multiple areas of stenosis too. In lumbar stenosis, you get leg cramping that is worse with standing and with walking. So this is literally going to be someone who has a job that involves standing and walking, like a pharmacy technician, right? Lumbar stenosis symptoms improve with flexion at the hips and bending forward, which relieves pressure on the nerves. So when you ever see a patient do any kind of maneuver in musculoskeletal, you want to kind of see why they're doing it. When you flex at the hips and bend forward, that's kind of assuming like a cradle position and like the way babies often sleep. That is obviously going to stretch out the spinal column. So instead of keeping it straight like that, you're stretching it out. You're bending to open all of these gaps up. When you bend forward, you open all these gaps up, which then relieves the pressure. Right? That's kind of what they're doing in this scenario here with the lumbar stenosis. Bending forward. So you're going to get that in questions, that the patient often has to bend forward to feel better, sleeps bent in a I'm forgetting what that position is called, but sleeping like a baby, like a little spoon or whatever. Right? Very, very important to catch those things in patients when they describe it. MRI is the main thing. You do the MRI, you're going to see the stenosis. Just like here with MRI, you can see the disc herniation. When you do an MRI, you can also see the stenosis where, it's causing a closing up and the nerve can't come out. So spinal stenosis. Treatment, in all reality, when this gets really, really bad for people, they're going to need actual treatment, not just NSAIDs and weight loss. So don't really end up picking that as an answer choice. These things will be answer choices, but these are things you could tell a person to do, and they can't all do it. Not everyone can take NSAIDs. We've seen how NSAIDs can be really bad for renal function, for people who have peptic ulcers, and anyone else that requires prostaglandins. NSAIDs are opposite of prostaglandins, right? Prostaglandins are protective of your stomach lining. If you have peptic ulcer disease, you can't take NSAIDs. If you have renal disease, you can't take NSAIDs. So NSAIDs are not great for everyone. Weight loss and abdominal muscle strengthening are things that no one does. So telling them to do it is not going to cause them to do it either. So then you always end up having to move to advanced treatment, where you do epidural corticosteroid injections to provide relief. You literally inject them at the source where they're having issues and pain and inflammation now from the stenosis. And if nothing is helping, this is what you end up actually having to do, which is surgical laminectomy, which is actually needed in 75% of patients. So that's going to be the ultimate answer choice to pick. Right? If you get a patient who's becoming debilitated, unable to function, can't do work, the pain is really bad, symptoms are widespread, you don't want to bother them with just epidural corticosteroid injections. So you could get a question where a patient has spinal stenosis, they're doing really bad, and they can't even work, they've had to take some time off from work, and then they're going to be like, what should you do to treat them? All of these can be answer choices. Everything. NSAIDs, weight loss, abdominal muscle strengthening, epidural corticosteroid injections, or surgical laminectomy. They're all going to be answer choices. This is kind of what makes CK hard, because they're all clearly, according to the book at least, correct answer choices. But the most correct answer choice for that patient's specific case scenario will be surgical laminectomy, because he's so debilitated. All right. So that's something you want to make sure you understand. You don't just pick an answer choice based off of an input-output thing. This is why we don't have computers acting like doctors. It's not just an input-output thing. It's more so about the whole scenario of the patient's life and how they're doing. All right. So keep in mind that that is a key thing for multiple organ systems, not just here. And then in the next session, we'll move on to osteosarcoma, talk about all the different types of bone tumors and their presentations, the ones that are benign versus the ones that are malignant, and so on. Right? So if you're sticking around, or if you have Discord open, You might see me back in here recording another session. If you're free, just come back and join. I'm going to take a break. I'll probably be back in like an hour to do another session because I'm off today. And everything I do today, I'm going to keep posting it online. So you'll see it. You'll get an email, hopefully. I can't control whether or not you do get the email. YouTube messes that up sometimes. But you have the playlist, so just check it whenever you're studying if you're looking for new videos. Thanks a lot for joining, guys, and just keep working hard. Keep revising on your own. Keep revising.